Hi, I'm Mike Gibson, Milt Packer. We're coming to you live from HA 2024. I think probably the most exciting trial presented here, Milt, I'll be honest, the Summit trial, looking at tirzepatide in people with heart failure with preserved ejection fraction. Exciting stuff. Share it with us.
Well, it is really amazing. One of the things that we've learned about heart failure and preserved ejection fraction is obesity is the driver. It's visceral adiposity that secretes adipocytokines that have anti-natriuretic and pro-inflammatory effects, and that really is what drives the development of HFpEF. And so we looked at tirzepatide. It's a agonist of GIP and GLP-1 receptors, which is known to produce a substantial amount of weight loss. And we created and designed and executed a long-term study looking at the effect of tirzepatide on major heart failure events in patients with HFpEF and obesity. This is the first trial where events was the primary endpoint of a trial of any drug in obesity-related HFpEF. So it was such an exciting study because we enrolled only 731 patients with obesity and HFpEF documented. The patients were enriched for events. We had entry criteria that specified a certain health status, exercise tolerance, history of hospitalizations for heart failure. So these were patients markedly increased for event rates. And the trial went on double-blind therapy, tirzepatide versus placebo, for an average of 104 weeks, 2 years, up to 3 years. The primary endpoint was cardiovascular death and worsening heart failure events with an alpha of 0.04 and KCCQ, clinical summary score, with an alpha of 0.01.
And what did you find?
So we found that tirzepatide reduced the risk of cardiovascular death and worsening heart failure events by 38%, P equals 0.026, and it markedly improved KCCQ health status by 6.9 points, P less than 0.001, also showed improvement in 6-minute walk distance, reduction in inflammation, improvement in every health index that we measured, improvement in New York Heart Functional Class, reduction in heart failure medications, all of these building a substantial case of heart failure benefits, not just on events, but on metrics that are relevant to patients.
So let me ask you the big question everyone wants to know. What's you pointed in your intro, maybe some of the mechanism, but are these people just feeling better after weight loss? Or do you have the causal pathways nailed down about how the drug is mediating this benefit from a pathophysiologic point of view?
So Barry Borlaug is presenting at the AHA our mechanism paper, which was part and parcel of the trial. And we also had a cardiac magnetic resonance sub-study, resonance imaging sub-study as part of the trial, which is being presented by Chris Kramer, also at the AHA. So we actually can answer your question. There was on CMR a significant between group difference in left ventricular mass, a marked reduction in visceral fat around the heart. There was a meaningful reduction in blood volume, plasma volume. There was a reduction in troponins in the tirzepatide group, and there was an improvement in EGFR, an improvement in renal function at the end of 52 weeks. So we think there is a effect to there's an anti-natriuretic effect uh, that it reduces blood volume. There's a reduction in inflammation, which reduces troponins. That inflammation is probably related to visceral fat around the heart. So there's a reduction in LV mass, probably because of a reduction in fibrosis, not a reduction in hypertrophy. But we
Ah,
also saw a reduction in systolic blood pressure, which was pretty meaningful. Um, the most exciting thing is that we have biobank blood samples. So we are capable of measuring an enormous number of pathways that are relevant to our mechanistic story.
well, Mill, you answered one of my questions. I was going to say, okay, so the LV mass was reduced, but the skeletal muscle mass story is fascinating. There's a lot of evidence that it's adaptive, that you're really not reducing skeletal muscle mass, but maybe some of the fat that's intercalated between the muscle fibers. But it sounds like here, the fibrosis finding is fascinating because I would have thought that was permanent, that it wouldn't regress. But you're saying the fibrotic changes may regress.
Well, we didn't measure fibrosis, we measured only LV mass, but I would honestly indicate that fibrosis, I know so many cardiologists think fibrosis is a permanent change,
Right.
but fibroblasts are in a dynamic state. They come, they go. The collagen that they secrete also is in a dynamic flux. Fibrosis is definitely reversible.
Wow. Wow. Okay. So it wasn't just reducing the fat between the muscle fibers, it was reducing the LV mass, and some of that may have been fibrotic. Wow. Fascinating. Well, was there any reduction in mortality? I know it's a small study.
Oh, it's too small
Too
to
small.
look at that. But it was the most important driver of the primary outcome was a reduction in worsening heart failure events leading to hospitalization or urgent use of IV therapy.
Yeah.
So these were real heart failure events. The number of deaths is really too small for any analysis.
Well, we always want to add the number of years to people's lives, but we also want to add life to those years. With your kind of endpoint, it looks like you're hitting both. You're helping people accomplish both those goals. So very, very exciting. Great to see so much activity in this space. Congratulations on a very
Thank
well
you so
conducted
much.
study.
I'm
Thanks,
I'm
Bill.
really delighted to have spent time with you and told you the story.
Thanks, Bill. And thanks to all of you for joining us here live from AHA 2024.